We do reporting about what activities, but it allows us great freedom to really design and deliver the services that people need, whether or not they're billable services. And we've been in operation since April of 2012. So our primary care services, that the employees, as an inducement to come, they pay nothing to come get any of our services. And you see we have a dietitian, primary care physician, care coordinator, which I'll get into in a moment as to what that is, medical assistant with more training and responsibility. We have a physical therapist who's a specialist in pain, because by looking at the claims and talking to people, we heard that chronic pain is a huge driver. A clinical pharmacist, I know some of you are particularly interested in that role, and I'll explain it some more. Licensed clinical social worker, a nurse specialist, and that's our team. But we focus on coordinating care. We do care transition planning so that we meet with every patient who's hospitalized and we make sure they understand what their condition is, what their medications are, and do home visit afterwards to make sure that they have everything they need so they don't get readmitted. We average, we kept track of, we average a week, one contact a week with our patients, and they have on the average 9 chronic, conditions in their problem list. So, and we don't, as another inducement to the health plan, actually to save money, we provide a lot of in-office laboratory, which both helps us clinically, because you have, every time I see a person with diabetes, I know exactly what their A1C is at the moment. But it also is a way of, A1C at Stanford Hospital is $196 or something like that. So we don't, it lowers the cost that way. And we also have as a care support program, so people who are happy with their primary care elsewhere, and yet they want health coaching, or they have a particular health problem that they're focusing on at the moment. They need help with their goals and action planning on that, or weight loss or improving their health habits. And that also is free to Stanford employees. But, and some people then become more familiar with our program and sign up for our primary care after learning about it through care support. We practice human-centered design, and I advocate that if you have a program for people with complex conditions, or you're setting one up, talk to people first about what they're, and don't just think you know what they need. We interviewed 34 Stanford employees at length and paid them to tell us about their experience in trying to manage their chronic conditions, and what worked for them and what didn't work for them, and what kind of services they think would help them. And actually it took us a while to recruit. It was very challenging to recruit people. That Americans hate to shop for, look, they're shopaholics for everything but healthcare. They really hate to change health plans or health care providers, even if they're not happy. A year into it, we interviewed people again who turned us down, and they're on the left side, the people who, that's how their, came out of their interviews, how they were feeling about their health care, and then people who accepted our services and how they feel about being Stanford coordinated care patients. And it was really validating in a way to find out that we did achieve what we set out to achieve, at least for our patients. And it also helped us in our marketing, because they, I'll show you a couple things. The people we paid initially to be our advisors, many of them have continued as our patient advisors, and they meet monthly to make sure we keep on track and be patient-centric. So they don't like you talking about chronic diseases. They have ongoing conditions. So if you're out trying to recruit people to your program, they'll say, well, I have high blood pressure and diabetes, but I don't have any, they're managed, I'm not sick, I don't have, they're not chronic. Yeah, ambulatory intensive care, we threw that out even before we started, and named ourselves coordinated care. They don't like group visits. They like having seminars, however, so that's what we call our group sessions. They detest being managed, having their care managed, but they do want support. And so that's why our program is called care support rather than care management. And that's a term that we use all the time, care management, and it really doesn't ring true with patients. And, you know, they go, my doctor, or this is what doctors do all the time. So is this my nurse, or this is my medical assistant? And really, actually, it's the patient's nurse and the patient's medical assistant. So it's a way in which we frame our teamwork, and so it makes teamwork acceptable to our patients, and they know that the physicians and everybody values the team. So the central question is, why wouldn't a person with a chronic condition do everything they can to live long and feel well? And Hagar has some answers to this. If you go to the doctor and you're saying, eat 5 a day and get 30 minutes of exercise a day, and anytime you find yourself wagging your finger at somebody, they're going to stop listening. And really is all about, you know, what can somebody realistically do and have some success? And because a lot of people are either don't know what to do or have tried it and failed. And we call that the post-traumatic stress disorder from the healthcare system. Every patient, our initial visit actually is 2 hours long, because we really want to get to know people, and we have an interview process that to talk about all the domains that impact their health. And so that's what social support they have, you know, whether they have a home, are they underwater, or, you know, what's their credit card balance, to, you know, the medical neighborhood, what kind of access to care they have, what has been their experience with care, their self-management and mental health, you know, whether they have depression or have had depression or really have, stress is a big issue as Stanford employees. That, you know, their work schedules are unrealistic. And then actually the medical status and the health trajectory. So every single one of our patients has complex health conditions. But this is a really important thing to know, is where are people's assets and where are the liabilities, because you have to address the problems and support their assets in their care. We also assess the patient activation measure on every single one of our patients, and we repeat that every 6 months. And because the overt focus of our program is to promote self-management. And actually, we do are enrolling, trying to enroll 70% of our patients in the chronic disease chronic disease self-management program. So I'm glad to hear Jennifer made a push for peer support. But the patient activation measure was developed by Judith Hibbard at Oregon Health Sciences, and she actually has a lot of literature on it, and she's been following a cohort at Fairview Health in Minnesota for 27,000 patients for a number of years. And so it's a nuanced, it's an evidence-based test, a nuanced test, and there are questions that really elicit from patients, do they feel responsible for their health? You know, that's the number one. Do they know what they should do? You know, are they able to get the kind of information they need from health providers? And are they able to act on it and act on it sustainably? So a level 4 person, my husband says that, you know, they get a notice that the world is going to end in 10 days, and they try to get to go out and get their 5-mile run in that day. But you know, level 1 is you know, people you have to treat differently. You have to interact with them differently. And it's very helpful. Some people really feel motivated. They would do things but don't know what to do. So they're the people who need health education. And they need to meet with the pharmacist and spend some time on, well, how do you live with your diabetes from day to day? Or participate in a self-management program. Or link up with a peer group online or in person. So it's one of our outcome measures that we aim to improve the patient activation measure of our patients, and by teaching them and working with them and supporting them in their self-management effort. So you'll see, I think you said, Jennifer, that 30% of the population do what they need to do, and they'll figure it out. that's out of Judith Hibbard's population. That's sort of the distribution she got. Depression is a big issue with people with complex conditions, and you know, a super utilizer is another expression that patients don't like. We call them frequent visitors. I guess it's a different way of saying it. But depression is associated with 50 to 100% increase in healthcare costs. So behavioral health person is an integral part of our team. And I don't think I have a slide, but we all sit in the same room, you know, and so we can interact. We meet many times a week. You know, we present all the new patients. The medical assistants present all the new patients to the team, and we just make sure how we can best serve the patients. And by sitting next to each other, we hear a lot of conversations about patients and really work together on that. It's depression interacts or impacts or is impacted by a lot of chronic health conditions, and sometimes is a real obstacle to getting better or being able to activate yourself. We actually, just an aside, there's a lot of people who are either frequently admitted to the hospital or to the emergency department or have immense social or substance abuse problems or even medical issues, have a high score of adverse childhood experiences. And this was a metric that was developed by Vincent Felitti at Kaiser in San Diego in the obesity program. Some people just had refractory obesity, and it turned out they had a high score or high incidence of adverse childhood experiences. And actually, they're very common things, and some high-achieving people have overcome a lot of things, but it is part of what we open up the discussion to people, and we actually, our behavioral health specialist, we didn't know it when we hired her, but we found out about this as we were working, and she does EMDR, eye movement rapid desensitization. I always get the words a little mixed up, but it's a special therapeutic modality for people with adverse childhood experiences. But even just acknowledging it sometimes is really important to people. So it's part of the context, it's part of what people bring to their care. But that people with higher scores of adverse childhood experiences are more likely to smoke, have lung disease, and depression, and suicide is 12 times higher than substance abuse is also the numbers right up there. And anyway, it's a whole nother talk. So one of the things I think that we've learned, and it's very important whether your patients are, you know, in a safety net or in Medicare or in a private health plan, is focus your care, and particularly for people with chronic health conditions, what bothers you the most? You know, where do you want to be in a year? What are your health goals? And first and foremost, we address their health goals. And as part of building a relationship, it's part of building the trust, because you know, medical compliance, you know, correlates highly with how they trust their healthcare team. So, and you know, one of my first patient who had a brain, how many at a time, okay? Had a brain inflammation, you know, and was falling down a lot and had been hospitalized several times with fractures, and because she was on, you know, steroids and immune moderating drugs, had fractures that didn't heal, and she said, I want to go to Europe this summer for family reunion. And I went with her. We actually, one of the things the physicians do is I went with her to a specialty visit, and the neurologist was, you know, saying, well, I don't know exactly what this is, but if we do another MRI and a brain biopsy, maybe I can tell you. And I said, was that going to make a difference in your therapy? And he said, no. And the patient looked at me and said, I'm out of here. And we took her back and worked with our physical therapist so she wouldn't fall down, because that was really the thing that was in her way. And she got to Europe for her family reunion and didn't break anything. So, you know, it was her goal was not necessarily to find out what her diagnosis was. So her goal was to get on with her life. Yeah, so clap. That was but if I hadn't known that about her, I would have gone to a specialty visit and, I don't know, had a different outcome, I'm sure. I'm sorry that I feel like it always seems like we're weeks away from getting the data about the return on investment for our program. I can tell you, I have a case study, and person by person, it feels like we're making a huge difference, but we've had some obstacles in getting access to claims, and change of the third-party administrator, and legal people don't want our biostatistician to see anything. But so we're actually quite interested in Judith Hibbard's using the patient activation measure as a surrogate for potential cost savings. And I'll draw your attention, this is out of her Fairview population, and I'll tell you, you can add a 0 on for every one of, that's how much our patients cost per year. Very expensive. But if people move from a level 3 to a level 4, right, which is becoming more activated, then they're compared to people who are level 3 in both time periods, their healthcare costs are lower, right? And this is over a 5-year period. And people who move from to a level 1, from a 2 or 3, their healthcare costs are lower than people who've been in 3 and 4. So
Anne, can you just pause on that slide? What is the source for this? Because, and Amanda, can you make sure that you get that linked there?
It's, actually, I'm sorry I don't have the actual reference on it, but it's from Judith Hibbard's data from Fairview Health System in Minnesota, and where they've administered the patient activation measure to 27,000 or maybe 30,000 patients now over a 5-year period, and track their health costs, because Fairview is a whole health plan, and they have the data. So that's a way it's easier to all know the problems with health claims or lag behind, and what goes in them, what goes out of them, where people are catastrophic, what do you do? But the patient activation measure is there's a body of literature saying that it's something that not only can it be an outcome in itself, but it can be a measure, a surrogate for cost savings.
So maybe before we post the slides, Amanda can help you insert a slide that just gives the source there. And is that in the Health Affairs 2015 that you mentioned?
No. Okay. It's in another Health Affairs. So in Humboldt County, they're also showed, and I'm going to show the Pacific Business Group on Health and our data about the patient activation measure. And they were able, the levels, people in level 1, 2, and 3, the number of people in those categories fell, and the number of people in the category of higher activation rose. So they were saying that's a positive outcome. And this is out of the IOCP, the Pacific Business Group on Health, with the 15,000 patients over 3 years. And actually very interesting, this is the Medicare population. Look at how many of the 25% of their people were in PAN level 1 to start with, whereas in Judith Hibbard's population was 10 to 15%. So it just shows you every population, and that makes sense as the older you get, and they have a lot of people homebound and infirm. You really are not always confident and capable of following through on what needs to be done. But they were able to have the similar results, and that basically the shift was towards higher activation. And here, this is also interesting. Look at the percentage of our patients who start out at level 4. They're pretty high achievers, but doesn't mean they're not having problems managing their health. But and so we have relatively few people who are level 1 who just not. I mean, part of it is because you have to take an active step to sign up for the program, and change your doctor. So we naturally got the people who are more motivated in the first place. But again, we have over time been able to increase the activation measure, and we are hoping that will reflect a decrease in cost as well. There's some other metrics from the Pacific Business Group on Health, CMMI group, for a 3-year program. They use the VR12 as a measure of physical and mental health functioning, and showed an improvement in those. The PHQ is PHQ-9 is a depression score, So they were able to decrease depression, and so you know what that does for people, how people feel, but also how they utilize health services. And then showed an overall increase in the patient activation measure. And they had a lot of the groups had a criteria for graduating from the program. You know, if your problems were resolved or your self-management, was enhanced, you could graduate. And so people who actually were enabled to be more capable of self-management were more likely to graduate from the program. In terms of what other value have we achieved at Stanford Coordinated Care, we have the 99th percentile in Press Ganey likelihood to recommend, and for 19 out of the last 20 months. And 1 month, somebody got into the program who really wasn't eligible and got furious. I mean, the numbers switched from, but nevertheless, it's impressive. We feel like that says we're doing the right thing in terms of patient satisfaction. And that we we utilize My Health, which is our electronic portal, and phone calls instead of visits a lot. We have video visits and telephone visits as well, because we don't get paid when people come in for visits, and people really appreciate that. We've been able to fit in their busy days. We actually, the doctors take 24/7 call for our own patients, and I don't get called that much, but when I do, it often reverts an emergency department visit, because I know the people. We're doing well on our HEDIS measures, and that we have, which actually is the total province of our medical assistants. The doctor, they handle all the HEDIS performance measures, and I'll explain how we do that.
Who's the they?
The medical assistants who are in our program, and that's another part of the teamwork part that I want to explain that's applicable. Yeah.
I may have missed it. How did you say if you don't get paid, how does
we get paid per member per month.
Capitated.
Oh, capitated.
Yeah, capitated. Excuse me, but we don't bill the patient, and we don't have to do all the paperwork involved with billing, which actually helps my satisfaction. There's some things that, in private practice, spend 35 or 40% of your time for billing, right? And that's not patient care. But, and one of the things that, one of the things, if you're having a program for screening people, that'll drive your costs, potentially drive your costs up, because we did find people with breast cancer and colon cancer. Anyway, we found that we really wanted to improve the control of blood pressure, and I know this is a overt focus of this group. And we have a number of protocols which are available on the Stanford Coordinated Care website, but our pharmacist does hypertension control, but also hyperlipidemia, diabetes, asthma, and COPD, all by medical management protocols. And we also have a protocol for our medical assistants to help with a follow-up for people who in the office have greater than 140 or greater than 150 blood pressure. But you can see over time, we've improved. And that's an important part of, yeah.
Oh, I'm just wondering about what caused the dip between July of 13 and February 14. It's kind of interesting that there must have been a systematic thing going on, a turnover of personnel or something like that caused that change.
A lot of time, you mean we went down or up?
Yeah, so if you look at the green bar got smaller. And the red bar got bigger. And the
right.
One, yeah.
Some, we're enrolling new patients all the time. We've actually found our quality metrics, including the patient satisfaction, correlates with our staffing levels. So we're out some staff. People don't get the appointments they want.
Right.
And so I don't know exactly. That's a really good question. And that's part of what we try to do is look at our data, but we haven't really digested this yet, other than we made some new protocols for measuring blood pressure, making sure we're doing it right. If it's high, we have a plan, for following it up.
But yeah, if you had a high enrollment period and you didn't staff to it because you're lagging behind, that would do that.
Yeah.
Gotcha.
So before you move from the blood pressure side, since that's such a big focus here, can you say anything about the new guideline for people over 60 and that conundrum about control blood pressure versus falling, and are you addressing that in your clinic?
Well, you know, I'd love to see that because it's come up. You know, the primary care at Stanford is adopting some of the metrics that we've, you know, they're finally starting to measure metrics on, they didn't. They thought because they were Stanford they were doing a good job, but sometimes that's true. And that's, yeah, that is and they haven't changed the dashboard yet for, you know, there's a certain number, they'll still look like they're red as opposed to yellow or green, even though the care might be appropriate. And part of that is having made up or delved into the literature on a lot of these metrics is the different societies responsible. You know, have often are different in the guidelines, and it takes a long time for guidelines to filter through. So if, you know, I'd be interested to see what you've done. We haven't come to a consensus what to do about it, other than we don't back.
This is just JMC 8.
Yeah.
And then we just note per Neil Kohatsu, your other classmate, the Medi-Cal medical director suggested that we just do an asterisk noting that the greater than 60 should rise to 150 over 90 is still in professional discussions nationally.
Right, right.
But really just that issue with your very delicate patients, since falling would be part of the complex care that you're dealing with.
We don't have, I mean, there are professors at 85 and 90 who are still there, but by and large, most of our population is between 55 and 65.
Okay.
So, and it's less of an issue for us than it would be if we were trying to have a Medicare program. But I'm honest with you, we haven't figured out how to do that. But they're still, and that's why another reason why you never expect to get 100%.
Yeah.
You know, there are people who just won't get a pap smear, and there's people who just won't take their medicine, people who shouldn't. And that, or it's the least of their worries. If they have metastatic cancer and they have 3 months to live, who cares what their blood pressure is?
Yeah.
Yeah.
Right, and just to segue into that is, and related to that is your focus is on patient-centered care, right? And you're activating the patient, and you're wanting the patient to reach what they set their goals are. So I can see this as a practicing physician prior to, in the past, where the patient can say, I really don't want to take this medicine because it makes me dizzy and I cannot do what I like to do, which is going to parties and so forth. So the conundrum for the practicing physician then is, how do you make sure that the patient is still achieving the goal that they want, but also achieving the standard of care that you want?
Right. So as I said, we focus first and foremost, and I just picked up a patient who was, and we have them all the time. His A1C is 13.8. That was something very high, not good blood pressure control. But that's not their goal. So I can't go into that until I get to know them longer. And we have, then sometimes patients go, well, we actually have a report card that we give out to people that follow some of their metrics over time. And they go, well, this is red. You know, red is on fire, yellow is smoldering, and green is kindling, we say. If this is red, shouldn't I be doing something about it? I said, well, do you want to do something about it? We can help you. But it's not what we jump in first. And I think that is a conundrum about quality metrics. And I think ultimately, hopefully, we'll show that by focusing on what the patient's goals are, and with people with complex conditions in particular, have been through a lot of things where medicines made them fall down or feel horrible, or they're allergic to like more medicines than I ever knew existed. It's tricky, but that's why we focus on the relationship. Yeah.
And are you capitated for the hospital piece too, as well as the institutional?
No, we're just capitated for primary care.
Yeah.
For what we do within our four walls.
Are you partnering with the hospital for that piece?
We do, to the extent that we do care transition, for example, but we get notification when our patients, any Stanford employee or dependents admitted to the hospital, and then we go offer our services and do care transition. It's an uneasy relationship in the way that the health plan, the university is part of the health plan, And the university is one of the biggest customers of Stanford Hospital, right? And so it's both a cash generating, but you know, so our services cut down on their income on one level, but save money for them another way. And it's a challenge. A lot of health plans and hospitals don't appreciate cost saving as much as they do as cash generating.
They're learning.
Yeah. That's another conundrum, right? We're coming up with a whole list, and you really hit on them. So out of the CMMI grant and the program, they said, what are some of the elements of the successful program? So there's 500 medical groups or 23 plans that participated. You have to have support if you're going to do a program, whether it's emergency department reduction or you know, hospitalization reduction or high-risk OB prevention or whatever one of those 7 areas you're focusing on, or even redesigning primary care so you can retain people. You need senior leadership support, you know, dedicated physician champion. You have to identify the appropriate patients, and I talked a lot about that. You have to, if you're at risk like we are, you know, we're capitated, it's easier to make that because we have a shared savings agreement. So we're really interested in saving money for Stanford. If there's hospital integration, that really helps a lot. And when there's an entire population health strategy, which we've developed at Stanford, we're trying, you know, the chronic disease self-management program and pre-diabetes program for people who are not sick enough to be us, but are on their way if we don't do something. You have to have an analytic capacity to set your metrics and adapt to the local environment. And the financial and performance incentives really get providers on board.
Can you elaborate on that a bit? And also, I just want you to know you have till 1:45.
Yes.
So you
I
have
do. I don't
plenty
have
of
to rush.
time.
Okay.
Plenty of time.
Good. So what did everybody see that? I think we went through that. The one thing is adapting to the local environment. Every program has a different environment, have different providers, have different patients, and they have different preferences in a whole different context. I think that managed care got a bad rap in California when it first came out, but I really feel like that's the savior or allows us to do this kind of redesigned care, because they're the kind of things that people need, particularly with complex conditions, are not the kind of things that always get billed, billable. And the coordination code is a step in the right direction. If the payers are united in the community, that really helps. And Care Oregon has had amazing cooperation from the different payers of Medicare, Medicaid, the private payers, and the hospital systems. And that's a real shining light in that. And in Denver Health, by virtue of being the biggest system in town, has really been able to coordinate a lot. And communication is very important. And actually, what we like at Stanford, and I didn't have this when I practiced in Humboldt, is we have the same electronic health record. I can see what's going on in the hospital, and they can see what I've been doing, and my patients show up with an annotated problem list. It's very helpful. And I worked on health information exchange in the state, and that was haven't gotten there yet, have we, Jessica? Okay, so a little bit about team care, and this is the part that's applicable to any kind of primary care. But